Hello. Today we are going to have a focused physical examination on respiratory and cardiovascular system wherein we will use inspection, palpation, percussion and auscultation over the back and chest or thorax of the patient. We will need to follow the institution's rule in examining a female patient who will need to expose her chest. We need to use proper draping to expose one area at a time. In this video, we will keep the patient's shirt on. Today, have a female student nurse to watch the examination with the patient's consent. During the interview of or history taking, I will be able to observe and verify symptoms and signs of respiratory difficulty, which could be tachypnea or respiratory rate 25 and more per minute, audible wheezing, supraclavicular retractions of sternocleidomastoid muscle and scalene muscles, and cyanosis or pallor of the skin around the mouth and nail beds. With the patient's health history in mind and after hand hygiene, I would start further examination starting on the patient's back. Miss M, I will inspect, palpate, and percuss and listen to your back, okay? I'll show you how I'm gonna percuss on your back. It's gonna be like this, okay?
Okay, stop.
For the posterior chest, during the inspection, I will take note of the shape and movement of the chest. I would check the color and condition of the skin. Normal breathing should be effortless as shown in depth, rhythm, and equality of both right and the left. I should also check for the use of intercostal muscle during inspirations, which is also a sign of respiratory distress. For the palpation, I would be able to check swelling, temperature of the skin, and presence of sinus tracts. I will palpate for chest expansion. I will wrap my hands over your rib cage, just like this. I would place my thumbs at the 10th ribs, raising a loose fold of skin in between, and other fingers spread over the rib cage. Take a deep breath. This would normally show as my thumb and fingers spreading with equal lung expansion on right and left lung. I will palpate for tactile fremitus. I will use my palms to feel vibration simultaneously on both sides, between the scapulae and the spine on the apical part, above the tracheobronchial tree, below it, lower lobes and bases of the lungs, at posterior axillary line. Can you say the word 99?
99,
One more.
99,
One more.
99,
One more.
99.
Thank you. The vibration should be symmetrical, not decreased or absent, nor increased. Positive findings should be correlated with percussion and auscultation. For the percussion, I will firmly press on the distal interphalangeal joint of my middle finger, the pleximeter finger, to the lung field, with the other fingers not touching the chest wall to avoid dampening of the sound. With a quick strike with the other middle finger, the flexor finger, and equal pressure in every strike, characteristic sounds will be produced. I should start at the apices and down toward the bases, alternating on the right and left lung in a ladder pattern, and note for symmetry. I will follow the 7 places, 14 on both sides, between the scapulae and the spine, on the apices, upper lobes, lower lobes, and bases, close to the posterior axillary line. I will mark where the dullness was produced by the diaphragm. Using percussion, I would be able to approximate the diaphragmatic excursion after finding the dullness produced by the border of the diaphragm below the lung base. I will ask the patient to take a deep breath and hold it as I percuss and look for resonance of the lung that would descend another 3 to 5 centimeters. Miss M, take a deep breath for me, please, and hold it. You can breathe out now, thank you. I should do that on the other lung, and it should be symmetrical. For the auscultation is best performed with a skin contact with a stethoscope to avoid the extra sounds produced by clothing. The diaphragm of the stethoscope would be used, and both the inspiratory and expiratory part of each breath should be listened to in every listening area. I will use the same areas in the percussion part and do the latter fashion as well to monitor for symmetry. Miss N, give me a cough to clear up your airways first. One more, please. Thank you. I would need you to do slow and deep breaths with an open mouth. If you're getting lightheaded, we can pause for a while, okay? I would start from the apices as well. I will also auscultate for the abnormally transmitted voice sounds of bronchophony, egophony, and whispered pectoriloquy on the spot that I palpated and percussed where there was an increase in tactile phlebitus, dullness, or consolidation. Miss M, say the word 99, please.
99.
Say E.
E.
Now, can you whisper the word 99?
99.
Whisper, please. Thank you. Miss M, while you are in upright position still, I will inspect the symmetry of your breasts. Arms up. Lower your arms a little to the sides and lean forward. Arms lower more. Straighten. Straighten your arms on your sides. And lean forward more. Then lower your arms a little. Thank you. You can relax now. These various positions for female will ensure to visualize dimpling and retractions in breasts, areola, and nipples. Now I will need her to lie down so I can check the heart pressure reflected in her neck, and I'll do further checks on your breasts also, and then your lungs and heart. Okay? She's now laying at 30 degrees. I would have to differentiate between the pulsations from carotid pulse and the inward oscillation of the internal jugular vein. It is the oscillation of the IJ that I need to measure against the sternal angle. I would place a ruler in centimeters on the sternal angle, which is 5 centimeters from the suprasternal notch. And extend an object from the highest point of oscillation to cross over the ruler in a 90-degree angle and measure where they intersect. I will then add 5 centimeters to the value that I get. The sum would be the JVP. And I get 2 plus 5, so it's gonna be 7. Now I'm gonna check the carotid pulse. While the patient is supine, I will palpate the carotid pulse with index and middle finger at the lower third of the neck, at the level of the cricoid cartilage, and check for thrill. I will auscultate for bruits below the jaw so it won't be affected by the sounds produced by other arteries. Now I'm gonna check the anterior chest and further examination of the breasts. Examining the anterior chest would let me check for abnormalities such as bruises, injuries from fractured ribs, tender spots, muscles, cartilage, tender spots on muscles and cartilage, and lumps as well. I would also palpate for the trachea that should be in the midline. Otherwise, the presence of pneumothorax, pleural effusion, or atelectasis. Raise your arms up to your head, please. Up to the head. Rest there over your head. Thank you. Examining the anterior chest may also reveal some findings through inspection and palpation about male and female breasts, such as tenderness, lumps, nipple discharges, presence of swollen and tender lymph nodes, axillary and clavicular, rashes, and infections may be noted as well. Using the vertical and horizontal lines intersecting at the nipple, noting the tail of Spence or the clock pattern may be used in locating the palpated lesions. Elevating the head while in supine position would be needed for easier breathing, especially in the presence of COPD, which may even require a sitting position and leaning forward in severe cases. I would now palpate for chest expansion as I did posteriorly and note for symmetry. Miss M, I will wrap my hands around your rib cage. I will raise loose skin folds between my thumbs with my other fingers spread over the lateral rib cage, which would normally reveal equal lung expansion. Take a deep breath for me, please. Thank you. For the palpation of the lungs, I will palpate for tactile fremitus as I did posteriorly. I will palpate simultaneously over the upper lobes, lower borders, and at the bases over the anterior axillary lines, and note for symmetry. Say 99, please.
99.
Say 99.
99.
Louder.
99.
Say 99.
99.
Thank you. Positive findings should be correlated with percussion and auscultation. For the percussion, I will start percussion at the apices and down toward the bases, alternating the right and left lung in a ladder pattern, and note for symmetry. I will follow 6 places, 12 for both sides, apices, upper lobes, around the tracheobronchial tree, lower borders, and lower lobes and bases at the anterior axillary line. Dullness over the heart and liver, which will be needed in estimating the liver size, would be noted. Tympany from gastric air bubbles by the left lower rib cage would be noted. I will start the percussion now, okay? For the auscultation, the diaphragm of the stethoscope would be used, and both the inspiratory and expiratory part of each breath should be listened to in every listening area. I will use the same areas in the percussion part and do the latter fashion as well to monitor for symmetry. Miss M, give me a cough to clear up your airways again. One more. Thank you. I would need you to do slow and deep breathing with an open mouth. If you're getting lightheaded, we can pause for a while, okay? I would start from the apices as well. I will also auscultate for the abnormality of the transmitted voice sounds of bronchophony, egophony, and whispered pectoriloquy on the spot that I palpated and percussed, where there were an increase in tactile fremitus, dullness, or auscultation, or consolidation, I mean. Miss M, say the word 99, please.
99.
Say E.
E.
Now whisper the word 99. Thank you. Now we're gonna go to the heart. I will do palpation on the heart. Thrills are created by the turbulent flow of blood or murmurs inside the chambers through the valves. I will palpate with the ball of my hand over the 6 listening areas of the heart. The 6 listening areas are the right and left second intercostal spaces, or the aortic, that's on the right side, and pulmonic on the left side. And they're just below the second rib at the sternal angle. The third spot is the left sternal border at the third interspace. And the fourth spot is the fourth interspace, and those two, the third and the fourth interspaces, are the tricuspid areas. And the apex, which is at the fourth and fifth of the left interspaces at mid-clavicular line. I will be able to feel the pulsations from enlarged right ventricle with my index, middle, and fourth fingers at the left sternal borders on third and fourth and fifth interspaces as well. And the index finger firmly pressed over the epigastric area, pointing to the left shoulder, will be used to check for right ventricle pulsation from the hypertrophy of the right ventricle. So now I'm palpating the aortic area for thrills and the pulmonic area. The third interspace, the fourth and the fifth interspaces on the left sternal border, which are the tricuspid areas, and the fifth interspace, the fourth and the fifth interspaces at the mid-clavicular line on the left side for the apical impulse. But right now we're palpating for thrills, which are brought by murmurs. And here's the epigastric area. If we want to palpate for thrills from the right ventricle, we can firmly push and point towards the left shoulder. Thank you. Now we're gonna locate the heart's point of maximal impulse. I would need the patient to change to left lateral decubitus to better feel the pulsation or the systole produced by the left ventricle at the apex. I will start locating that with 2 fingers and then with 1. This position, or sitting and leaning forward, are also used to listen to S3, S4, and murmurs from mitral stenosis and aortic regurgitation. So this is gonna be about at the fourth and fifth intercostal at the mid-clavicular line. Thank you. Now for the auscultation of the heart, I will auscultate over the 6 listening areas again for S1 and S2, S3, S4, and other extra sounds, and the bruit from murmurs. I'm gonna use the diaphragm for listening to the S1 and S2 at the aortic and pulmonic areas, and with the bell going down up to the apical area to listen for the S3 and S4 at the apical area. Now we're gonna check and auscultate for abdominal bruits. Abdominal bruits may be auscultated over the abdominal area at the epigastric area. We're also gonna check the renal arteries below the rib cages on both sides, the iliac arteries by the umbilicus, and the femoral arteries at the inguinal areas. Miss M, I will listen and palpate your abdomen as well, okay? Now when we check the brachial artery, palpation of the brachial artery is medial to the biceps, tendon at and above the antecubital fossa with my index finger and my middle finger. Checking the adequacy of brachial pulse, especially on patients with carotid obstruction, kinking as in obesity, and thrills. Check the epitrochial lymph nodes as well for tenderness and swelling. Checking the peripheral vascular system also include checking the radial pulse, and the ulnar pulse, and modified Allen test may be performed for the adequacy of the ulnar pulse. The circulation on the legs is also done with palpation of the femoral, popliteal, dorsalis pedis, and posterior tibial pulses. The color and condition of the skin on extremities, its temperature, presence of skin lesion, swelling, sores, lumps, varicosities, and swollen and tender lymph nodes should be noted. And Homan sign test for DVT may be performed.